Thanks, Iona. Nancy, are you back with us?
Don't think she is yet, Alison. We'll give it a couple of minutes. If not, I'll walk along to her office.
Okay, lovely. Thank you very much.
Sorry, she just popped into the other invite to tell people to come to this one.
Lovely. Thank you. I'll just give it, if you don't mind, Lena, I'll just give it another minute.
Oh, no, absolutely.
I've let them know. So
Thank you.
But I think there are others still joining the trust one. I can see that coming through.
If we were together, we'd be having a cuppa now and some biscuits, no doubt. Or maybe fruit if we were going to be really healthy.
Oh dear. Lovely. Okay, I think people are beginning to join now because I can see the numbers going up. So great. Thank you very much. And welcome to our QI showcase. February the 27th already. I can't believe that. But anyway, this morning we have two great projects being presented, but we also have Lena Samuels with us. And so it's great pleasure for me that I'm able to welcome Lena, Chair of North London Foundation Trust, who is going to share her insights from her personal visit to Australia, during which she also had the opportunity to meet with healthcare services. So I'm going to pass over to Lena first, and then we will have our other two presentations following that. So welcome, Lena.
Thank you so much, Alison.
Do you want to move to the next slide, Anna? Thank you.
Thank you. Thank you so much. I'm really delighted to be here. So I did take a visit and nobody laughed to go and be part of the crew that went to see the Ashes, the cricket. And it was lovely to be in a very warm place, so that kind of dented some of the disappointment. But always wanting to explore what other people are doing, I did take the opportunity to go and see a few people. So I did see the chief psychiatrist of Victoria, and they were absolutely brilliant in their energy, and they described some of the models of how they function with providers in acting as the sounding board for critical and complex decisions that need to be made. So it enabled clinicians to have a bit of a kind of a safety net. So that was a really good meeting. But the one I wanted to talk to you about today was the visit to the Australian Centre for Social Innovation, because of course innovation is key and at the heart of how we need to try and do our problem solving. And their kind of sub-strap line is innovation for better lives. And that kind of fits in with the kind of purpose and direction in terms of how we work. It's quite often easy to go to other places and think, well, your conditions are different, and so of course you'd be doing things differently. So when I, sort of did a bit of interrogation and looked into what and how they operate, the environment that they're operating in, they have exactly the same issues that we are facing in terms of the economic environment, the environmental environment, and also some of the clinical presentations that they're having to deal with. So the multiple indices of deprivation and illness are absolutely resonating for them. And I've listed some of those there for you to see, including, AI, of course, presents opportunities, but also it brings with it some risk factors, as well as things that we need to be acutely aware of. So, they understand the context, and they have taken this centre a very novel approach to how they are solving some of the challenges by working in a very different way as a public organisations networking together across entire systems, geographies and place. And so collaboration, as we know, is at the heart of it. But they also recognise that some of what we do as healthcare practitioners could inadvertently marginalise individuals. So they really do place people at the heart, front and centre of what it is they do, and they truly involve them. And when I went to visit their site and I went up into their building and I went up the stairs, it was just so beautiful because, every step had a little message on the return. So you walk up the step and there's like a values or an uplifting statement on every tread as you go up the stairs. And that kind of really told me as I was walking into what was in a very colourful environment that it was a very welcoming place, and it was connecting deeply to people through how that centre, even though it's really there's a sort of the hub, the mind of where everything gets created and developed and then pushed into the community. But it did kind of give you a sense of what is this organisation about? How does it look and feel to be part of them? So some of the things I was really impressed with was their peer-to-peer networks of support. What they do is they understand obviously some of the issues, but they don't overlay that with, we know best, but rather they empower individuals within community settings to think about how they can support and help each other. So thank you for moving that on. So for the last 15 years, as it says there, they have been working very successfully on peer-based initiatives. And I heard that actually some of it has gone into Wales and I believe into Stoke-on-Trent, where they've been, some of the models of what they do has been adopted. And you'll see from the list there, all of the different contexts and strands of activity that they get involved in terms of setting these up. So the example that they gave me was working with a family that may have been going through, the family was experiencing domestic abuse. And of course, this was putting pressure on that family unit and consequently on the vulnerability of the children within that setting and affecting the mental health of people within that family unit. So what they do is they have worked with the principle that they train up another family who has gone through a similar set of circumstances, and then they get that family to do the peer-to-peer coaching with the family who are going through that particular issue. They're supported with all of the usual safeguarding kind of measures that you need to put in. And they're constantly checking, how is it working and what's the progress. But in a sense, it creates a safe environment for individuals to share what it is that they're going through without feeling that they are interacting with the state as such, when sometimes that can force people to close down and not feel that they're operating in quite a trusted environment. So they feel a bit happier and more able to share their vulnerabilities and the challenges that they're facing. And the family that's been down that kind of experience and has grown through it and has been trained, they act as the coach, as the mentor, and it creates the next opportunity for that family to grow, and then that next family to also consider whether they want to be a peer and provide similar peer-to-peer support, to help that family grow and deal with their challenges. So on the next slide, the family by family approach, which is the one that I've described, and it talks about helping people to work through those really, really tough times. And it does a lot in terms of building confidence within families, because we know when we're dealing with people who've got a mental health crisis or a mental health issue, it isn't a singular line. It's not just one thing. It becomes multifactorial, and including, having stable and secure housing, as we know, is one of those factors that can affect somebody during or even when they have left our estate and are going back into a community setting. So it's good that these are operating within the community setting, and then the practitioner, who is the expert within, let's say, our trust, would be the one who would host it, would monitor it, would make sure it remained a safe and appropriate way for support to be delivered. So the organisation always retains a link to it. And there's another example on there of where they're supporting carers. So we know that they're the unsung heroes in a sense that support, family members who are going through challenges, and those people who are caring are often forgotten. They're not supported. Their mental health gets affected, and their vulnerabilities become attenuated. So it's making sure that everybody within that community setting is getting support, rather than, in a sense, us saying we're only looking after that person, but actually we need to ensure that there's resilience wrapped around the person that we're caring for, with the carers who are looking after them as well. So as I said, so they are very focused on assessing what it is that they do and making sure that it's working, and they have been doing it throughout the programs that they've been running over the 15 years that they've been working, particularly on this. And if we go to the next slide, we'll see that what they have seen in terms of the work that they do is sort of stating the obvious, but we know that it's really hard to kind of create an agenda this within individuals and make sure that it's a sustained way of thinking and feeling. So of course people feel much more supported, the growth in their self-esteem and their confidence, helping them, become much more rounded in terms of what their lives are packaged with, in terms of education opportunities, and ensuring that they get the support that they need to get employment, but also sustain that employment. It's about creating those networks within communities between people. And of course, with a 10-year plan, one of the core aims is to ensure that we're working within neighbourhood settings. And this is a really good example of how you can empower activity within neighbourhoods and energise it so that it can carry on forward under the umbrella of an organisation such as ours. They've noted that of course, it reduces the amount of interface that's needed then within professional services. And in particular, they noticed that the use of emergency services was significantly reduced because people weren't having to go into a crisis situation because they had a safety net in their community already, and that had been developed to good effect. And then as we go to the next slide, it'll be back to the beginning in a sense in terms of where I started. And I wanted to share what they have on their website. And I'm happy for you to share this afterwards, and for you to have a look at why words are so important to them, because it's the words that land in people's consciousness, in their minds, in their emotions. And they've got some, great things in terms of, ensuring that they've got rigor in their imagination in terms of what they do when they are experimenting. They align very much to the values of ensuring that people grow and learn together. And I think that's the kind of one of the core QI principles, in a sense, isn't it? In terms of, if we're going to improve, we can only improve by doing it together. It's not a sole person journey. It's very much harnessing the wisdom, the practice, the imaginations and creativity of the many in order to create a new way of working, to experiment with that in a risk-based managed way, with the appetite to do things differently and increase the quality of lives, improve it for the people we look after. So I'll pause there because my throat's about to give out, and I'll grab some water, but I'm happy to answer any questions.
Thank you so much, Lena. Anna, do you want to take down the slides just for a minute, and then I can see people. Really fascinating to hear what's going on over there, and interested to see that it's been adopted by gosh, I'm started now, adopted by some people in Wales and England already. Does anybody have any questions at all for Lena?
Whilst you're thinking of anything, and I won't be offended if you don't have anything, but I'll be delighted if you can think of something. But one of the things that struck me was the guy who runs it used to be Director of Strategy for the Design Council in England, and he was recruited to go over there to do like a 9-month project. And then 9 years later, he's there and he's got a family and he's settled and what have you. So I can understand why.
Thank you, Lena. Victoria.
Hi, Lena. Thank you for sharing. It's just an acknowledgement that we appreciate your sharing your experience and also having a talk with our colleagues from the other side of the world, bringing what you've learned there to us. It's a beautiful experience, and we hope we can learn from them as well to help shape the services that we provide to the economy and also to the community that we work in. Thank you.
Thanks, Victoria. Parsa, have I
Sorry,
pronounced it right?
Victoria, thank you.
I thank you, Lena, for sharing. This is really interesting. I'm just wondering for the families who are actually doing the peer-to-peer, who are taking the lead to support the other families, are they getting any payment or any kind of how does it work with them? Who's training them? Who's like supervising them to support the
Sure. So the Centre for Innovation does the training and supervises them and supervises the entirety of how the peer-to-peer work takes place. I'm not sure about the payment. I have a recollection that he did say that they did get some level of support for doing what they do. But I think mainly it was the opportunity for those peer mentors to grow and learn, because whilst they were then going on to support another family, their journey of learning continued continuously throughout it. But it's certainly something I can certainly find out from him and let you know. Thank you.
Lillian.
I always feel like whenever you call me Lillian, I always think I'm in trouble.
I'm so sorry. I'm sorry, Lil. It's only because I was reading names on the screen.
No problem at all. But yeah, it's so interesting to like hear what you've observed, and it's basically just incredible to see such a sophisticated sort of structure and system that's basically wrapped around what is ultimately co-production, and absolutely everything that we do within our organisation should be grounded in lived experience. And it really supports us to sort of shift culture. But I guess my question is, how do we as an organisation support our each area to have peer workers? Because I understand the current climate and finances, it's not as easy to do, but you know, you've very much clearly shown us how crucial it is to the development of our organisation and our services.
No, great question, Lil. Thank you. So I think there will be some opportunities because, of course, with the new way that commissioning is going to happen, there will be a shift of funding into community settings. So that could potentially provide us with the opportunity to begin to model what we want to do in discrete areas. And you can't change the entire world in one go. But I think, you know, we could certainly look at, well, where could this work? Let's get it motoring there. And for each other, rollout, you would tweak it in accordance with what the demands of the service are and what people, who are experiencing it, what their feedback is. So I think now is absolutely the time for us to start thinking about what are we delivering in community settings? How can we deliver it differently? Because I think the money will follow that.
Thanks, Lil. Phil, if I just take the last three hands up. So Phil.
Yeah, it was just an observation, and thank you, Lena. It was literally, I just saw the word gambling there, and I just wondered, and it might be something that I need to sort of ask Chippo about children and young people. Having my son's just gone to uni, and it's quite interesting that he was telling me the other day how many of his friends are caught on the gambling apps. And actually are in debt, not only the uni debt, but they're in thousands of pounds worth of debt already. And it's something that I think is going to be could easily be our next sort of epidemic in terms of risk and mental health. And it'd be interesting to see what we do as a trust, comparing that obviously where you visited, it's been highlighted.
Yeah, no, I think that's a really great observation. And I have to say, gambling is one of my pet areas of interest, let's say, because I know how easy it is for people to get caught. And then we know that there's a high instance of completed suicides because of the financial distress that people find themselves within. So there's certainly, I think it's certainly something we need to give some consideration to. I know when I was applying for my role as chair and I was doing an assessment of what the needs were across every single borough, unbeknownst to me, Haringey had a high instance of gambling challenges and issues. And we probably don't talk enough about it in terms of what can we do, how can we approach it. And I'd really value a further conversation about it so we can think about whether this is a strand of work that we need to give more prominence to.
Gosh, that's really interesting. Thank you.
Yeah.
Thanks, Phil, for asking that. And there's been something recently on the news as well that I remember seeing about how the links with mental health and how it's affecting so many families now.
Yeah.
Claire.
Yeah, hi. Sorry, I missed the first 5 minutes, but thanks, Lena. That was really interesting.
Pleasure.
And as one of the kind of longest standing peer support workers within kind of the trust, it's obviously of kind of deep interest to me. And I would really love to see kind of more investment in this because it's just so obvious that it's the way forward and that it does work, you know, not with, I mean, I'm within mental health, but I mean, I've got experience within kind of using peer kind of mentoring and coaching within drugs and alcohol and gambling as well. So it's and it is just such a supportive environment, and the outcomes are definitely a lot more kind of positive when you're working with people that have got that lived experience, have been through it and coming through. And knowing it's that hope, I think that you're able to give, or they're able to see that it is possible to actually kind of claw themselves out of such kind of situations, I think. And it is across the board. It doesn't matter what it is. If it's domestic abuse, poverty, even poverty, you know. And it's just I don't know. It's just really interesting, I think. And I think it as a trust, and we cover such a vast area now as well, you know, with the 5 boroughs, that I think something kind of needs to change within the way we are engaging with and supporting our communities, you know, because there's a massive lack of resources for people out there especially in certain boroughs or certain kind of areas of certain boroughs, you know. So that was totally. It. So thanks a lot.
No, totally, and thank you for sharing your direct experience, you know, professionally from what it is that you do. And you're absolutely right. The results, I think, do demonstrate for themselves. And as humans, we do get inspired by other people, don't we? If we've seen someone overcome a challenge, we're like, how did you do that? You know, so actually I can make that change in my life, or I can do this, or I can reach out to somebody else for support and help. So I think, you know, it definitely merits further conversation.
It does. And I know the people I've worked with as well then, and other peers and peer coaches and mentors that are in the trust. I think we're there. I think we're not necessarily kind of called upon enough to kind of get involved in stuff, but also then knowing that the people that we work with, the service users, the people that use our services, they then have an interest in, how do I get involved in this? Can I do it as a volunteer, or can I do it as a full-time kind of job? So it's almost like if we invest in it properly, we have then got a workforce, I guess, as well, to kind of come through that could be of better value to the community we serve.
Thank you. And I'll pick it up with our Director of Neighbourhoods as well. On the back of hearing about people's interest, I should pick it up and see what we can do going forward. Thank you.
Thank you so much, Lena, for sharing your insights from Australia. And I'm sorry that the cricket wasn't so good, but at least you had a great time and were able to come back with all this absolutely fascinating information. And yes, as you said at the beginning, it is really taking those quality improvement principles forward in everything that we do. So thank you very much. I don't know whether you are staying or whether you've got to dash off, because I know that this was fitted in with timetable.
Doing so. Thank you so much again, and I'll hang around. Thank you.
Thank you, Lena. So, Anna, we've got it on presenter mode here. Do you want to put it onto a full screen? Thank you. So, Mac, is Mac with us?
Yes, indeed.
Thank you very much. So we've got a really interesting presentation now by Mac, looking at improving one-to-one engagement with service users in medium secure inpatient wards. So I'm going to hand over to you, and Anna, are you able to get the slides up?
Thank you, Alison. So yeah, my name is Mac, and I'm an inpatient matron in the North London Forensic Service. I would like to also introduce my team members. I think one of them might be on the call. Danielle Ken, she's the ward manager for Juniper Ward, and her deputies, Abdul Limbat and Chika Gude, her deputies.
Mac, can I just stop you 1 minute there?
Sure.
Anna, we've still got it in presenter mode.
Is it? Oh, okay. It's not full screen. Sorry.
It's not full screen, or it wasn't for me. Was it for everybody else?
It wasn't for me neither.
So it's really difficult to look at it.
Right. Still is.
It might be on your other screen, the actual full slide deck, Anna. Sometimes it splits across two.
Yeah, that's true.
I'm happy to share, Anna, if you're having problems. It just means that I won't be able to see everybody, so you'll have to let me just get it up. Is that? Can everybody see that?
We got it.
Lovely.
Yeah.
Okay, let me just get to the right edge. There you go. Okay, thank you.
Okay. All right. So yeah, just to say, it's my first time presenting here as well. So thanks for having me. A couple of years ago, when I first stepped into my role, I was asked to review the care planning process on Juniper Ward, which is our 12-bedded medium secure female ward. We wanted to see greater nurse involvement. Basically, the level of nursing engagement in that area wasn't where we wanted it to be. So we did this project initially to improve documented one-to-one nurse engagement with the aim to ensure that each patient on Juniper Ward received at least one documented nursing one-to-one session per week, achieving 90% compliance by 30 April 2025. We started this project around September of 2024. As we go through the slides, hopefully it will become clearer why we decided to do one-to-one engagement when we actually wanted to improve care planning. Next slide, please. Next slide.
All right, it's not moving forward for me.
Technical problems. Oh dear. It's not. Okay. Thank you. Oh, let's go back to.
I'm really sorry.
That's okay. We'll get there. Yeah. Okay. So thank you. So to help us understand the problem, we looked at 3 key areas: the workforce, the patients, and the records. Starting with workforce, we used ward clinical governance meetings, we had stakeholder meetings to discuss care planning process and existing procedures, and where we could adjust, make adjustments. We also facilitated several focus groups with nursing staff to understand their perspective. A number of core issues emerged, as indicated in those word bubbles there. Firstly, there was resistance to change. Some embedded practices had been in place for a long time, and not everyone was keen to shift them. Juniper Ward has 2 consultants, so that's 2 leading 2 clinical teams. Each team has got 6 patients. We had immediate buy-in from one team, but met with some challenges, some resistance from the other team. In that team, the consultant completed all the care plans and they were reviewed at CPA. We wanted care plans reviewed more regularly. So having 2 teams working in different ways created challenges for us. Secondly, there was skepticism about whether nurses could deliver care planning effectively. In some cases, nurses had been told not to touch care plans. There was also an example where a nurse completed a care plan and it was immediately deleted. One comment made about care plans during the discussions was that no one looks at them anyway. And that was true because the nurses were not really that involved in them anyway. Over time, this led to a de-skilled workforce and understandably demoralized staff who felt their professional contribution wasn't being valued. From a patient, next. If you can click next, there's something else on that slide that we need to look at.
I'm really sorry. Iona, are you able to share the slides?
I've just taken it over. Can people see these slides now?
Yeah. Thank you. Next. Yeah, I'll back a bit.
There you go. Sorry about that, Mac.
Yeah, no, that's okay. That's okay. So from a patient perspective, we conducted a survey. 83% of patients said they knew who their name nurse was. 50% reported having regular one-to-one sessions. However, when we started to review the real records, only 17% of those surveyed actually had a recorded one-to-one on Rio. So we identified a gap between reported practice and recorded evidence. Next slide, please. So to explore these issues further, we use the fishbone diagram, such as the one you see there, to help us to identify and categorize the possible causes of the lack of documented one-to-one engagement. Several themes emerged, and we grouped them into those 6 cause categories: people, process, equipment, environment, materials, and training. Our driver diagram, which is on the next slide, is not very clear. It's not, as you can see, it's not very clear. So if you just go back to the other slide, thank you. So if you will indulge me, I'm going to also talk about our change ideas as I go through these cause categories. In thinking about change ideas, we were conscious that we try simple ideas, keep things simple. So starting with people and training, we had a de-skilled and demoralized workforce. There was clear resistance to change, skepticism about the value of care plans and whether nurses could deliver. Also, if nurses didn't feel care plan was their responsibility, then issues around leadership, oversight, ownership, and accountability were inevitable. So to address these issues identified within the people category, our change idea or ideas centered around primarily on just teaching and training. So more than anything, what nurses were telling us is that they wanted permission to perform their duties fully and professionally. As soon as we went back to basics in terms of just teaching them fundamentals, reinforcing the nursing process, empowering them, reinstilling core values. We began to see noticeable shift in confidence, morale improved, and more importantly, practice began to change. We also enabled our deputy ward managers, who are our clinical team leaders, to have a stronger voice. They began to, they kind of became the first layer of oversight for clinical documentation, also providing guidance and supporting in real time. As nurses began to deliver consistently and competently, the skepticism we had previously encountered began to gradually dissipate. What we learned was simple and powerful. When we equip our staff, empower them, and support them, what we see standards, expected standards will be sent. We also carried out a survey, a staff survey, and of the 8 we surveyed, 80%, which is 88%, said changes had been very positive. 75% reported receiving adequate training. 88% also said they felt comfortable delivering one-to-ones. 63% said weekly reviews were manageable. 88% said that documenting became easy when we implemented the changes. And looking at equipment, there was limited and inconsistent use of RIO features. The diary function, for example, river view was something I actually learned during this project. And also the care plan library was underutilized. So RIO system had capability, but we felt it wasn't being used to its full potential. So to address the equipment issues, we focused on teaching staff the basic mechanics of RIO. We went back to kind of fundamental basics of how to write and update a care plan properly, how to use the river view feature, for example, to review notes, and also to make auditing more efficient. We also introduced standardized documentation headings to streamline workflow. So for example, we asked them to put headings like one-to-one name nurse engagement, which made it easier to search through RIO if you're doing auditing. By improving digital confidence and standardizing documentation structure, we were able to make the system work for staff rather than staff working against the system. In terms of materials, the structure and usability of care planning documentation at times posed challenges. There was a long list of, if you know RIO, the way that it's structured, you end up with care plans stacked up, long care plans, and it's very difficult to navigate. So we again focused on making RIO work for staff rather than allowing it to become a barrier. One key issue was the languages used within RIO, which didn't always align with the kind of language we use in everyday nursing practice. So we simplified the structure. We used the main care plan categories as overarching domains for our care plans, kind of grouping them into 5 domains, which I will show you later on. And by organizing care plans in this way, it made it more clear and made documentation clearer, more intuitive. And under process, we identified several workflow barriers. There was no clear operational definition for one-to-one. Documentation practices were inconsistent. Care plan reviews were not embedded into kind of routine nursing activity. So one of the biggest barriers was the perception that one-to-ones can only count if they are done in a very specific way, in a designated room, for example, or for a set amount of time under certain conditions. So we work to strip away those rigid expectations. Instead, we encourage nurses to just go and engage with your patients organically during the course of the day, and then apply structure and documentation afterwards. For that reason, we abandoned the idea of protected one-to-one and other overly prescriptive procedures. And looking at the environment, it was a very busy ward with constant competing demands. There was no dedicated interview room, for example. So again, we encourage staff to use the environment more flexibly. One-to-ones didn't have to happen in a designated room. That could take place naturally within the flow of the day. By removing these restrictions, staff interacted more frequently with patients. We made it acceptable to have conversations about anything, recognizing that meaningful engagement doesn't always start with a formal agenda. One nurse told me that they took a patient out and did a really good conversation while they were out on community leave, and she was like, "Mark, can I document that as one-to-one?" I said, "Absolutely. That's exactly what we want, adding value to all the daily interactions that we have with patients." All these factors helped us to understand that the issue wasn't about individual performance, it was about the system, the culture, and the structure. Next slide, please, which is unfortunately our driver diagram, which is not very clear there. So apologies again. Our primary drivers were culture, clinical leadership, and collaboration. And second drivers were education and training, staff support and engagement, real documentation, monitoring compliance, patient engagement, and co-production. I've already touched on the change ideas, and we adopted most of them, apart from the one for protected time, which we abandoned. Next slide, please. Thank you. So what you're seeing in the middle there is the template, the structure that we wanted to use. And as I mentioned earlier, the ultimate goal was to improve the care planning process, but it quickly became clear that there were foundational issues we needed to address first. That's why we centered this project on improving NEM-nurse engagement before focusing on care planning. That was our general strategy. Once we began to see sustainable improvement in our one-to-one engagement, we knew that we were building firm foundations. From there, we could confidently move forward with improving care planning processes and other aspects of clinical practice. So what we did is we went back to basics. Training was centered on basic fundamentals, the holistic care, mind, body, soul, things that people could relate to. We revisited care models, the nursing process, to help us create this kind of universal standard template, which aligned with care planning, as you can see, the daily progress notes, care plan reviews, and our handovers. So staff could use that one template for all those areas. We also had to kind of mirror the language used in Rio. You see it says psychological there, but that's actually a care plan that covers mental state. Risk, obviously, was that the risk management, any restrictive interventions, enhanced observations are covered under that domain. Physical health, self-explanatory. The social one would sort of cover care plans on therapeutic activities, the leave, occupational therapy, engagement, and so on. And when staff document on Rio, they would use that same template. When they review the care plans, they're also referring to that same template and handovers and so on. One area that is often overlooked is cultural and spiritual support. So approaching this from a holistic perspective ensure that these kind of important aspects were not marginalized. Discharge planning is something that we had to add because it's one of our KPIs. So we were kind of obligated to incorporate it, but it also aligned naturally with our wider objective to improve patient flow. At the bottom there of the slide is a heavily redacted example of an actual Rio entry that we are doing. So you can see the example there. Next slide, please. So in terms of outcome measures, on the top left is a run chart of the data collected in life QI. On the bottom left is the same data but analyzed in Excel, and it shows 50% improvement in the documented one-to-one engagement. increasing from a baseline of 44.6% to 88.7% of recorded one-to-ones. The red and spider charts at the bottom there represent a process measure. They demonstrate how well the standard care plan was embedded into practice. So on the left is I think that's from November, and you can see that only 3 elements: psychological, physical, and social, were addressed in the documented care plan review. This was for a care plan review, not the kind of daily notes recording. That was just a care plan review. And that same patient's care plan review in January, you can see that all the elements were addressed. So not only did documentation increase, but the quality and the breadth of reviews also improved. Next slide, please. Thank you. So whenever you implement change, there's always the risk of unintended consequences. So we were very mindful of this. And as we introduced these changes, we wanted to ensure that we didn't negatively impact patient experience and well-being. This was necessarily, it wasn't necessarily about saving money. It was about using existing resources more effectively to improve care. We monitored indicators such as staff sickness, the use of restrictive practice, enhanced observations, and the potential impact on temporary staffing and ultimately our headroom. The 2 graphs on the left there show short-term and long-term sickness data from Power BI. But I would like to draw your attention to the one on the bottom right. You can see in orange, that's the total sickness, and that fluctuated as you would expect. However, the work-related sickness shown in blue was not negatively impacted at all. Next slide, please. So the graph on
I think I'm going to have to ask you to speed up a bit because
okay, I think I'm getting there. Yeah, that's probably the last slide, I think. So the graph on the left shows 86% reduction in enhanced observations on Juniper ward. And that was an unexpected but positive balancing measure that coincided with our changes with being fully embedded as well. So showing sustainable improvements in engagement and documentation. The graph on the right shows a reduction in temporary staffing costs across all the wards. That's partly driven by the decrease in enhanced observations. So of course, there were other factors to consider, but it's reasonable to infer that this project contributed to these improvements. And just to say, we've been able to roll this out to other wards, yeah, we've been able to. So I think I'll just end it there. That concludes our presentation. I just want to thank Anna Spiteri for your support with this project, and Gary for sponsoring this project as well. I will hand you over to Anna now, and I'm happy to take questions. Thank you for listening.
Thank you. Thank you so much, Mac. Now, I just wanted to check before I go to questions, and I'm conscious of time. So next 2 presenters, Dr. Dina Kazizova and Felix, I just wondered whether you would be open to presenting on the next QI showcase, because I want to give you adequate time to present and make sure we give the time to yours as well. Are you?
Yeah, I'm here. Hi, Medina. I just wonder when is the next kind of time when showcase? Yeah,
I can liaise with you. There'd be another one in March. It's monthly, Dina.
Okay. Yeah.
Would that be all right? I just want to ensure that you have adequate time to present your work so that it's not rushed.
I think should be okay. However, I can't confirm it because I need to check it with my kind of diary, with my colleagues. And just Anna was great help in this project, but I'm not sure that she would be able to attend next meeting. But anyway, yes. And will I be the first then to present? Will our team be the first to present?
Yes, yes, you will. Yes.
Okay.
And I think usually we just have the two projects on, but today, obviously, I had Lena here first as well. So I just want to ensure that you get adequate time as well, Dina. So I'll liaise with you. All right.
Yeah, thank you.
Thank you very much for accommodating that. So Mac, great project. Really interesting to see all the work you've done, and it's prompted several questions that are coming up. So Lil.
Hi, oh, it's incredible, Mac. Like really, really good, and Danielle and team, like really good to see. And I just wonder, like, in terms of what feedback you receive from patients, like have they noticed like a difference in the care they're receiving? I imagine they'd be feeling more heard, and that obviously changes the dynamics on the ward. Yeah, but incredible, and you need to share this everywhere.
Thank you. So, as I mentioned at the start, we did a survey. We actually surveyed patients at the beginning, and their feedback was actually very positive. So that was then followed by CQC visit that happened just as we were starting to embed all these changes. And I think it was on one of the slides, very, very positive feedback from the CQC. They spoke to patients and got really positive feedback about care plans being well written, and that patients were receiving copies of their care plans. So we couldn't ask for more, really, with that feedback.
That's excellent. Well done to all of you. Samina?
Yeah, Mac, well done. Really great project. And I noticed, Lillian, you sent me a message separately. So as an organisation, we do the Patient Carers Race Equality Framework as well, which is about obviously supporting our patients from minoritized groups, Black and minoritized groups, in things like patient experience, because we don't get much patient experience from there's low numbers in existing patient experience information, whether it's friends and family and stuff like that. So I'm just wondering, is it something that we could build on? Because I thought the care planning criterias were quite interesting, but I was thinking, how could we incorporate things like language, accessibility, if they've got a disability and stuff? We know from a psychological perspective, if they've got severe mental illness, that will be classified as a disability. But I'm just thinking how we can build on the principles on the care planning to make sure that we capture that in terms of, and what would we do if a patient had a different language, for example, how would this be different for them compared to how would we adapt it so to make sure that everyone gets the same sort of treatment. So yeah, I'm happy to sort of touch base, especially if it's something that's being rolled out on other wards, to see how we can sort of tweak it to make sure that it enhances what we're currently doing. But I think yeah, it sounds really brilliant. Thank you for sharing.
Thanks, Amina. Anne?
Yeah, I mean, Mac, I'm so impressed with this because I think it's probably...
I can't hear you, Anne. Can others?
No.
Can you hear me?
Yeah, we can now.
Just get very close.
I'll be close. That's a bit scary to see myself like that close. Mac, really brilliant work, and I think it is a really hard project to nail, and you clearly have managed to sustain it, which I think is the biggest challenge, and I think that's so incredibly impressive. And can I just clarify, are you saying currently now the expectation still remains that it is once a week, really good quality documentation and evidence that people have been engaging with patients. Is that still the current sort of expectation?
It still is, yes. But what we did do is, at the end of the project, I was collecting data weekly, but at the end, I was collecting fortnightly. The reason for that is we tried to link the one-to-ones to ward rounds, and on that particular ward, they have their ward rounds fortnightly. So it made sense to give staff 2 weeks to meet with their patient and then have that fed back in the ward round. Linking it to ward round was one of the ideas to ensure that it's fully embedded. It's kind of self-sustaining because, you know, the deputy ward manager or team leader needs that feedback, that one-to-one feedback for the ward round. If it's not done, they're going to have to prompt the nurses to meet with their patients. So it kind of works well that way.
Thanks, Mac. Sarah.
Hi, thanks. Yeah, no, great presentation, Mac. Just coming back on Samina's point, which I think is really important about kind of accessibility in whatever form, and just reflecting on the fact that we had actually just tried this in terms of putting things into another language, and it's a nightmare. You need to not think of it being translated. You need to think about it about accessibility. So I think you need to use a more learning disability principles. So all our learning disability patients have accessible care plans. But when you translate it, our care plans are not nice. We were talking about it only yesterday in the clinical governance. If you put them out, if you're a patient, that is not what you want to receive. It is not helpful. It is helpful to us, and it's very good when the CQC come, and it's a very good collective point from care to roll out from. So I'm not saying it's not valuable, but from a patient perspective, I don't think what you print out and what you give to patients, even the font is not very nice. The structure is awful. So I think it's a massive piece of work, which I think is an electronic piece of work, but I think it also is, so there's an IT aspect to it, but I think there's also I don't know whether there's a package where you can apply accessible principles to that as a package, because that would be the easiest thing, because having done it for all our LD patients, well, we're talking about 22 patients, and that took one person an awfully long time with a high level of skill. So for hundreds of people, that's just not going to be possible. So I think it's really important, but I would suppose my cautionary note, given our recent experiences, don't look to translate, think about accessibility. There's massive issues around literacy, aren't there, which are maybe not language based, which is why the learning disability approach kind of cuts through that, but it's massive work. So yeah.
Thank you, Sarah. And I suppose my final point is, this is excellent work that has taken place in Juniper. Has it been shared across forensic services, and therefore what's sort of the plan for scaling up across forensics before we look at scaling up across the organisation? Because we don't want to reinvent the wheel all the time, and part of our improvement journey is to be able to scale up some of the really good work that's going on, as opposed to having to repeat it all the time. So I think that's probably a question not only for Mac, but perhaps for Phil and Sarah as well, as to how is this being scaled up in forensics before we look to explore.
So yeah, it's in fact our 12:15 meeting is about exactly that. We started our discussions on the back of this a week or so ago to kind of how do we know our care plans aren't good enough, and I think everybody would probably say their care plans aren't good enough, but what is it? It's not just about it. So we're going to share this learning, but I think it's then about trying to work out what the gaps are. People say I don't have time. Okay, what does that mean? What does time look like? So it's really trying to unpick that. So we have these meetings every Friday at 2 o'clock with all these wards, and that's what we're going to be unpicking in the next month. But it's going to be led by the staff rather than us telling people what to do, because I don't think that'll work.
No, really good project. Thank you very much for sharing, and an excellent QI showcase. And my apologies to Dina and Felix again that we are looking to rearrange your time slot, but I just felt as though wanted to give you adequate time and also not cut short Mac neither. So thank you to everybody. I hope you have found the session informative and have learned things from it, and we look forward to the next session in March. Thank you.
Thank you.